Before I move on to pain patterns, I want to make mention I didn't talk at all about looking at the fingernails. So, kind of going back to that previous slide on the other part, when you look at the fingernails, it could also tell you something about them. You look at Figure 6.6 in your textbook. There's different types of fingernail issues that could come about. So you can see the picture in the textbook of the normal nail, the nail that is clubbed or is a clubbing nail or a spooning nail. Depending upon what could be happening and different types of cardiovascular issues, you could usually end up getting some type of deformity in the fingernails as a result of that. So that could be something else that comes about as well, and we'll talk about that, see that with some of the conditions we're going to discuss. In looking at pain patterns, so again, that's another picture. I don't have it up here on the slide, but in your textbook, you could kind of see what the typical patterns are. And likelihood is in the emergency response class, you've kind of discussed what pain issues that people usually have when they're suffering from a cardiovascular episode. So we look at spinal level C3 through T4, and typically you look at the neck and throat on the left side and the medial portion of the left arm, which is illustrated in that picture, is usually what you're going to be seeing from a pain issue. And usually the cardiac pain, they'll describe it as a crushing type of pain. People who are having, again, for instance, a myocardial infarction or a heart attack, it basically feels like a lot of pressure on their chest. That's really painful and uncomfortable. And just in general, vascular pain itself. So pain of vascular origin is usually described as a sharp, a tearing, or a throbbing type of pain. If muscles are having a vascular issue, they will usually be cramping and feel very tired. Again, nerves you'll end up getting the numbness and tingling associated with that. So those are things that will typically come about in individuals who have vascular types of pain. So looking at the history and exam and some things that you would want to kind of look at in individuals when you're doing a history. Again, getting obviously a family and personal history, looking at some risk factors. One of the big ones being a history of sudden cardiac death in the family, and someone who's under 40 is a very strong risk. I also want you to kind of look at some of the other risk factors and be able to name those as well. You want to look at your general symptoms, some of which we have already talked about and discussed. Again, typically the pain of cardiac origin is usually going to be that crushing type of pain in the chest, and kind of referring into those other areas. Again, other things like fainting suddenly or having palpitations are going to be important. You could do your inspection, so kind of looking at the individual, look at their chest wall. Could be something that could lead you into something as far as being structurally significant about the thoracic region. It could also, in looking at them, you can detect Marfan syndrome, which is a connective tissue disorder that we're going to be talking about a little bit later. But the inspection could tell a lot in regards to that as well. And one of the basic vital signs you'll be looking at is your heart rate. So in measuring your heart rate, again, you want to look at what's a normal heart rate as far as the numbers. So the normal heart rate ranges in adults is between 70 and 100 beats per minute. In babies, it's a little different. Newborns have a slightly higher resting heart rate, between 90 and 180. Children's heart rates could go a little higher, so their heart rate ranges between 70 and 140. So that's what you want to kind of take note. A very slow heart rate is known as bradycardia. A fast heart rate is known as tachycardia. So a resting heart rate or resting bradycardia is typically less than 60 beats per minute. It's not It's not necessarily pathological. Individuals who are in very good condition will typically have a lower resting heart rate, particularly those who do a lot of aerobic activity like marathon runners. A high resting heart rate above 100 is called tachycardia, and that's something that should be always assessed and evaluated by a physician. And just in general, you also want to note, do they have a good strong heart rate? Is it a weak? As you're palpating it, is it very weak? And that could kind of tell you some other things that could be going on with the individual. Looking at your respiration rate, normal respiration rate for adults is normally between 10 to 15 breaths per minute. Infants have a higher breaths per minute, it's about 30 to 60. Young children are between 20 and 40. So that's something you want to note. Again, in addition to the rate of respiration, you also want to note if they have difficulty breathing. So is there any type of obvious dyspnea? Are breaths rapid? Are they shallow? So that would be something that you would want to kind of take note as well with the respiration rate. With blood pressure, so we're going to be measuring blood pressure typically with a stethoscope and a sphygmomanometer. That will be what you will typically use. There's other ways to measure blood pressure. Ideally, what we're looking at is a normal blood pressure. You're looking for it to be less than 120/80. That's what you're typically pretty much looking for. In adults, your systolic range will be between 100 to 140, and the diastolic will be between 70 and 90. Infants and young children should have a younger blood pressure, is what you'd pretty much be looking at there, but you want to be looking at the normal ranges for blood pressure. Again, ideally what you want to have is just slightly below 120/80. If you have blood pressure equal to or greater than 140/90 on consecutive days, that's you start to look at chronic hypertension being an issue. But that's pretty much the ranges you would like to be at with your blood pressure. So another step in the examination is something that you should do is heart auscultation, or just listening to the heart sounds. Now again, it's important, you're not going to be expected to be able to diagnose a heart condition based upon listening to the heart sounds. Your job as an athletic trainer is just to, again, pick up on something that just sounds abnormal. Okay, so the normal sounds that we're looking to listen for are what are called the lub-dub sounds. So it's the lub-dub heart sounds, or the S1 and S2. So lub is S1, dub is S2. They correspond to the closing of the different valves in the heart. So the lub sound corresponds to the closing of the mitral and tricuspid valves with ventricular systole. The second sounds, the S2, the dub, corresponds to the closing of the aortic and the pulmonary sounds after ventricular systole. So that's what you're listening for. There are some abnormal extra sounds. So someone could have an S3 or an S4. They are abnormal extra sounds. Some people may have muffled heart sounds. Some people may have, again, abnormal murmurs, or they may have what are called bruits, so any type of clicking or pounding noises, or what basically sounds for almost sounds like blood's rushing through the heart kind of thing. So those are kind of all of the things that you want to be listening for. So what I would say is, from the standpoint of an athletic trainer, you want to listen for that lub-dub. If you hear the normal lub-dub, the S1, S2, again, the heart sounds are normal. Anything beyond that would be considered an abnormal heart sound. Again, a lot of your pathological things being the bruits, or even what are known as murmurs. Now, if you look at the picture on the on the screen. There's a similar picture in your textbook. Those correspond to the 4 listening sounds. So you have the aortic heart sound, which is located just to the right of the sternum in the second intercostal space. On the left side of the sternum, you have the pulmonic zone, which is located in the second left intercostal space. You go down the sternal border on the left side, you have the tricuspid, and then you go about, you kind of bisect the anterior portion of the chest, and you have the mitral zone, which is right in that 4th or 5th, the left 5th rather, intercostal space, kind of going to the midline of the clavicle. So those are the different zones that you're going to be kind of listening over. So, and that's where you're going to be, again, listening for your S1 and S2 sounds kind of going throughout the auscultation process. And we talked about this previously, the respiration rate, blood pressure, heart rate. Again, just know what your normal values for those are. We're not going to be practicing blood pressure in our class, but just kind of understand the process by which we take each one of these. Okay, so as we begin to look at different conditions that we're looking at in the chapter on the cardiovascular system, sudden cardiac death is something that obviously is one of the major things when we're talking coverage of athletics for individuals of all ages. This is something that becomes a big issue. This is usually something that will occur within 1 hour of the onset of exercise, so it is something that will occur then or even shortly after exercise. And sudden cardiac death is going to be caused by typically caused by some type of pre-existing condition that the person has that may just have never been picked up on. Some of the different causes: hypertrophic cardiomyopathy, some type of congenital coronary artery anomaly they may have, electrical conduction issue, myocarditis, also any type of rupture of the aorta. So a lot of the conditions actually that we're going to talk about can cause sudden cardiac death. Contributing factors, high intensity exercise, obviously one of the main contributing factors, particularly if somebody has some type of pre-existing condition, an electrolyte imbalance, high body temperature, also a sudden cessation of physical activity. So in other words, exercising really, really hard and someone doesn't do a cool down, and again, they have some type of pre-existing cardiovascular issue that can contribute to a sudden cardiac death event. So hypertrophic cardiomyopathy, and again, this is a condition that can cause sudden cardiac death, but it's another condition we're going to talk about separately. It's important to note there are different types of cardiac hypertrophy. So again, hypertrophy refers to an increase of the size of the cells, in this case the muscle cells of the heart. So you get the increased enlargement of the heart. So there's general cardiac hypertrophy, which is a normal adaptation to exercise. So people who are very fit and take a lot of strenuous exercise will get some increase in size of the heart. Again, that's a normal thing and does not cause pathology. What we get concerned about is abnormal enlargement, where there's an asymmetrical enlargement of the heart. And this individual people who have hypertrophic cardiomyopathy inherit abnormal cardiac fibers. There's a picture on the screen showing you somebody that has hypertrophic cardiomyopathy. And if you note the left ventricle, how this affects the size of the left ventricle. So if you look at the left ventricle in the first picture, look at the size of the left ventricle in the second, and the right ventricle in this instance is also affected as well. This is something very significant. It's a leading cause of death in young athletes. So if this does not get detected, it can be missed and can cause this. The issue that happens is with the asymmetrical enlargement, it basically causes a decrease in the size of the ventricular cavity, and what this can do is it can actually cause an obstruction of blood flow throughout the heart and then produce an arrhythmia or an atrial fibrillation, which is basically an abnormal quivering of the heart. So this actually causes a disruption, not only from causing issues with the vascular supply of the heart, but also, again, is something that can mess up the electrical conduction system within the heart. So it's important to note that. Again, note at-risk individuals if they had a close relative suddenly die under age 50, if there's any type of personal histories of syncope, chest pain, things of that nature. Again, kind of take a look at this, and again, for your signs and symptoms chart, note some of the things that could be that could possibly predispose people to this, and also note the different treatments involved. Another condition of note is coronary artery anomalies. So what happens here is you get an abnormal positioning of the coronary arteries. And if you remember, as we talked about, the coronary arteries are the arteries that supply the heart with oxygenated blood. The most common type is where the left main coronary artery gets abnormally positioned. There's a picture in your textbook, figure 614 on page 144, kind of showing a picture of an abnormal positioning of that artery. So what basically happens in that situation is that artery gets pinched off, and it's going to end up causing decreased blood flow to the heart. So again, that would produce ischemia and cell death, and then eventually, due to the abnormal blood flow, again, could possibly predispose somebody to an arrhythmia or a disruption in the heartbeat.